I'm not going to do full introductions because the speakers' bios are in your conference packet, but I just wanted to share kind of, this is a little bit of a full circle moment for me because Lynnley was my daughter's first speech therapist when we got this CACNA1A diagnosis, and we were having all of these challenges that weren't being addressed by her local speech therapist. So we drove to Kennedy Krieger every day for 3 weeks with Lynnley, and it was life-changing. And I basically called her again during COVID to help me when we couldn't get into our local speech therapist, and she did Zoom therapy with my daughter. She is an expert that we are so grateful to have here today. And when I approached her about doing this session for this conference, she actually went on the website, read all of the champion stories, so your stories matter. And she's like, I actually know a bunch of these kids. I've seen them. And so she actually has a lot of experience with our CACNA1A kiddos. I'm also deeply appreciative of Lynnley being here today. Her mom is incredibly sick, and this is a sacrifice for her to be here with us. And she is a little bit emotional and wanted to just make sure you guys were aware of why. So thank you, Lynnley, and your team, Rachel, Hayeon, for being here. And I think, as we said in yesterday's sessions, communication is a really important topic for our families, and I think you'll walk away with some really practical tips. Thank you.
So I'm a very empathetic person. I think it makes me a better clinician, but it also makes me this way. And I'm going through some health struggles in my family, so when I bring up all these emotions, it brings everything else with it, and I think you all can relate to that, so give me grace. When we look at, so if I want to advance slides, I'm going to use the green button. Green arrow, okay. So all of these common things that are on the slide, I don't need to tell you about. Your kids experience some form of them. At Kennedy Krieger, we see a lot of children with rare things, which gives us insight on some things and insight on nothing as well. So, sorry, I'm going to pull myself together. So I know communication is one of your biggest concerns, and so the things listed here, language development, feeding and swallowing, speech production, functional communication, augmentative communication, those are all things we want to try and touch base on, but I could be here for 7 days telling you all of these different things. So we have seen 7 kids with CACNA in the past 5 years. So we looked at those charts and just kind of pulled together, and we picked things that we think will be most helpful. And our goal is to end early and have a 15-minute question and answer period. And then also during the break, you just had a break, but I'll be available if you want to chat. So we're going to take turns talking about different things. Rachel's going to start first with some language development. So we're going to talk about language development. We're going to talk about communication and behavior. We're going to talk about oral motor, briefly touch on feeding, and then really get into augmentative and multi-purpose communication. So does that sound good with everybody? Okay, Rachel's going to go first.
Hi, everyone. I'm really excited to be here. Like Lynnley said, I'm going to touch briefly on language development from birth to 5 years of age, and also strategies that can be used within these stages of development. These are also just good strategies to make note of for communication in general. So from birth to the first year, this is when children are in the stage of pre-verbal development. So they're using vocalizations, sounds, sound combinations, and typically around that first year mark, we see that first meaningful word. In general, strategies that can be used are imitating your child. If they are saying a sound, say a sound back to them. Incorporate things that are fun, like songs, like animal noises. We love to use books with big pictures because there's a lot that you can do with them. From first year to 2 years of age, this is when kids are beginning to follow simple directions like give me, put in, take out. You're seeing some of that yes-no response to simple questions, and also starting to put some very simple 2 words together. So strategies that we like to use during this stage of development, simple naming of pictures and objects, duck, using functional routines for learning, so mealtime, bath time, snack time, bedtime, and just doing a lot of narrating. Simple narration of what you're seeing, what your child is doing, what they're hearing, what's going on in their environment. From 2 to 4 years of age, this is when we see language really boost and advance. So kids are starting to learn grammar rules, they're starting to ask why, and speech is becoming, the sounds are becoming more clear at this stage. And strategies that can be used really involve teaching new vocabulary, but making it very functional, so what pertains to you and your life and your child's life. And also another strategy to highlight is language expansion. So thinking about if your child is not communicating verbally, if they're using a device or something, you can also expand their language that way. So if you are hearing 2 combinations of words, you can add a 3rd word to it. And then from 4 to 5 years of age, we are seeing just more growth in language, both what they're understanding and then what they are communicating, longer sentences, using some more descriptive language, emotional words, location words, under, between. You're also seeing some of that early literacy begin, so print awareness, being able to know how to orient a book, where a title might be. And just some strategies here would be continuing to use descriptive language, really incorporating concepts, new words into daily life and making it as functional as possible and exciting. Now I am going to turn it over to Lynnley, who's going to talk about eating and swallowing.
We're going to talk briefly about it. I think there's other things you want to know about, but there's a couple areas I wanted to make sure we cover. Sorry, because I'm emotional, I'm having to rely on looking down at notes. So, when we talk about eating and swallowing, we really, as a professional, look at 2 phases. The mouth phase and then the swallowing phase. And things we look at is your child's mouth open or closed? If your mouth is open, that is sometimes what happens with low tone or kids that are having difficulty breathing through the nose. Many of your kids might have this. So when your mouth is open, we normally sit with a closed mouth resting posture. So you have to get to a normal resting posture to get your tongue moving for all the other things. So we start at a basic level of what is your mouth doing and is it in a typical posture? We also look at lip closure, we look at weaknesses, we look at coordination, and we look at chewing. Some kids also, because their mouth is lower tone, they might overstuff, or those kinds of things. And then on the pharyngeal phase, we look at speed and sensation and coordination, and differences there. It mostly affects swallowing of liquids and mixed textures is probably what you all experience if your kid is looking to be eating right now. So. So what I'm doing is I just thought I'd give you some basic quick strategies. You probably might know these, but if not, they're here. Things you can adjust, so try smaller bite sizes, try the pace of the meal, try presenting foods 1 piece at a time on a plate versus, so if your kid tends to overstuff, just put 1 piece on the plate at a time, and then you're not having a behavioral discussion about food in your mouth. Alternating liquids and solids can help. The liquid can clear out the food that's left in your mouth. Using adaptive equipment, and then also we can make dietary texture changes. Thickening liquids, taking foods and making them ground or puree can also help to manage them, but still getting it in. And the other thing I want to add in, especially for your kiddos, is looking at calorie boosters, getting the most bang for your buck when you're eating. And then the other thing I would consider is how long is it taking your kid to eat? If they're eating across an hour, you're burning more calories than you're taking in, which I know is hard to hear, but in the long term, with the pictures of your kids, you want them to have the best energy to do all the other things, right? So. The next thing I wanted to talk about was neuromotor speech impairments. So when we look at those, the kiddos, and I think your kiddos, have difficulty with muscle control, muscle tone and weakness. There's a difference between tone and weakness, and I think I'm talking to the experts on this right now, so I'm not going to get into that. But just differentiating what is strong versus what is weak, and then whether you have dystonia or other processes happening in that. And then motor planning, you can have problems with coordination, you can have problems with conceptualizing how to move your mouth, you can have problems with planning how to move your mouth, and you can have problems with, I know what to do here and I know what to do here, but programming it, okay? So those are all very different. And they're usually come out into the two main things you'll hear with your kiddos is dysarthria or apraxia. Dysarthria is the weakness, apraxia is the motor planning piece. We could do a whole lecture on this as well. But what I want to tell you is a lot of experts and a lot of doctors will tell you you have one or the other. With your kiddos, I find you have both. And so some people that have not seen rare and different things or work with a lot of kids with neuromotor differences tend to kind of go in those two fields. But I very often will see patients with weakness and motor planning problems. You may not have a full diagnosis of apraxia, but you absolutely have motor planning problems, and you have to deal with both, okay? So those would be things to look out for. And just to kind of hit what this whole conference has said, you all know your kids best. We know what we know, but you know your kids best. So make sure, like we talked in the last one, I'm not feeling heard, right? This is an unacceptable standard of care. I need to talk about this more. This is why I came, okay? So some strategies for some speech and oral motor differences. So you just want to make sure that the program your kid is getting is evidence-based. There's a lot of people who give a lot of advertising and marketing to programs that are not evidence-based, okay? So it's okay to ask your therapist about that. And you can talk to us about that afterwards. I'm not going to name any of the programs that I would avoid right now because I don't think that's fair. And not every program, just because it's not evidence-based, doesn't work. So it really has to be individualized is my next point. And then it has to be structured, and it usually has to be intensive. And intensive can be you meet initially, you get a really good plan, and then you work on it at home. Or intensive can be I go every day. Or intensive can be it's different for every kid and where you are in that phase. But it should be structured, individualized, and intensive for your kid, whatever that need is. And then it should be dynamic because once you reach something, you're not going to stay there. You're going to move to the next phase. So, and then strategies that we've also used is having bouts of intensive training. I'm a little biased. I work in one of those programs. I have kids that come to see me for 4 to 6 weeks at a time. I see them every day. I get 20 hours of speech therapy in a 4-week session, in a 4-week time. We can get a lot done versus 1 time a week. That said, there are times when kids do much better just 1 time a week working on things at home. You guys talk about it beautifully. There's inch stones. There's times where your kids need to rest and need to kind of work on other things and recoup. Then there's times where they are ready to work on their speech, or they're ready to work on their eating, or they're ready to work on their motoric patterning, right? So it's a dance. We also will use successive approximation approaches. It may not sound like the word at first. So we have a card. Let's see. Let you guys show it up, but so you accept something that's close to that word versus making it sound perfect. So this is a horrible example, but squirrel, right? There's a SKW in the beginning of that, one of the hardest words you can say. Your kid might say whirl or earl or right? And you might work towards whirl, then you're going to work to squirrel, then you're going to work to squirrel. Sorry, I went against the microphone there. So that's just some progressive changes. Our pacing boards are good. It's okay, we can move on. And then the most important part here is multimodal communication. Your kids have already figured this out. They're going to use the fastest, most effective method of communication in the moment they're in. And we should accept that, and we should encourage that. And then multimodal includes AAC, it includes objects, it includes walking to the door to tell you when to go out, or pointing to the door, or grunting and rolling towards the door to go out because that's what I want, right? That's communication. Your kid is communicating. They may not be talking, but they are absolutely communicating. And so research shows us, so lots of parents will ask us, my kid's not talking, and if I use this device, will it stop them from talking? The research is, no, it will not. It will help. It'll help with neural pathways. It'll help with decreasing frustration. So as hard as it is, I want you to know the research and the truth is, using any other form of speech will help speech, always. There are still, unfortunately, some speech pathologists who don't know that. but that's the truth. So multimodal communication, I want you to think of is it could be voicing, it could be gestures, it could be signs, it can be walking to locations, it can be using objects, it can be pointing to objects, it can be using pictures, symbols, and devices, okay? It's not just devices that you see in front of us. And you guys know that best. And the other most important thing I want to say is behaviors communication. Whenever I have any patient that's referred to me because they have behavior, first thing I think is they don't have a functional communication system, right? They're not being understood and they're frustrated and their behavior is communication, all right? So ways you can decrease this is you can do environmental supports, go to a quiet space, make sure your lighting is not distracting their eyes or other things like that. One of the things that my parents will say to me is, how do I know if this is behavior or language? Take care of the environment so that you can tell. So if you're in a rush or if the kid's not understanding or you're really frustrated, go to a quiet space. Make sure you're in their visual field, wherever that is, and then use gestures and things to make sure they're understanding you. If you still get behavior, then maybe you can go to behavior, right? Because our kids definitely have that, especially your kiddos. But just considering that. And then establish the context. So if for some reason, you don't know what your child wants. I hear this all the time. I want you to figure out what category is it. Hold up a diaper. Do you need a change? Hold up a cup. Are you hungry? Hold up a toy. Or do you want to play? Right? And you're going to put those objects in an area where your kid can see it. Some kids it's here. Some kids it's here. Some kids it's over here. So you have to figure out, work with someone who uses a structured method of figuring out with your kid's vision and understanding where is the best field for them to see that. If I say to you, would you want the diaper or the cup? But your vision is right here, you didn't even know you had choices. That doesn't mean you can't communicate. It means we didn't put it in a field where you can see it. Okay? Using visual schedules. Oh, so my other favorite thing is a lot of my kiddos, when they're done, what do? Shove it off the tray or shove it off whatever, right? So I use a large wash basket. I put it right next to where they shove things into the tray, and I call that my finish basket. And you can use it for anything in the house, and if it's a plastic laundry basket, you can shove anything you want in there and it'll wash out fine. So that's a great way to establish, like, I'm done with something. And if your kid's not sure they're understanding they're done with it, it's a great way to teach it, right? You're modeling it over and over and over again. So I think that's good about that. And then just quickly, speak slowly, which I'm not doing right now. Gain visual attention and make sure, again, that line of vision, where does your kid see best? And each one of your kids is different. And then acknowledging any communication attempt. So I'll have parents say to me, I think my kid is saying this. Yes, they are. Absolutely they are. Reinforce that. Repeat it back to them. Acknowledge it. Don't guess yourself or second guess your kid. You acknowledge every communication your child has and you assume it is. Okay? And then lighten the load. When you're tired, when your kids are tired, when they're sick, you can ask a yes/no question and get the same answer, right? And the kid only has to say yes or no. And other ways to say yes or no are So there's lots of ways to answer those where you don't have to have a lot of speech. So simplify your language, simplify your questions, give multiple choice answers so that they don't have to work as hard. They can have the language and have an exhausted body, and even then it's hard to communicate. So there's reasons why you want to support those things. And then the last thing that we're going to kind of talk about is 3-step guided compliance. And I like to say, show, do, or say, see, do. So I'm going to say, touch your nose. And if you understood me, you do this. And if you don't understand me, you can't get there, then I'm going to say, touch your nose like this. And then I'm going to wait for you. And then if you can't do it, I might say, let's touch your nose like this, and I'm going to help you. So say it first, show how to do it, and then help them do it. Touch your nose is a bad example for this crew, and I'm sorry, but that's what came to my head. But the point is, say it, show it, and then help them do it. And you are teaching and reconnecting those neural pathways for your kiddos. You're helping them. All right. And a big part of all of this is augmentative and alternative communication, and Hayeon's going to come up and talk to us about that. So she's going to take a good 10 to 15 minutes for this. So if we run out of time, we'll be available to talk after, okay? But I think it's important you hear this information. I think it's really relevant to all of you, too. So.
Okay. Alternative and augmentative communication, which I will be referring to as AAC, is something we picked because, one, we feel like a lot of our kiddos and a lot of individuals with CACNA1A has some type of a communication system, and something that we hear all the time is like, I see them do it with you, in front of you. I saw it with my own eyes, and when I go home, they don't do it. What happened? They're walking away. What happened? So we just kind of wanted to share like our thought process and some strategies that we use to work with our patients who have an AAC or communication system. So first, when you go to an assistive tech or AAC evaluation, you want to make sure that they're getting all of this information, all of these pieces, not just one, not just two of them. We want them to consider their background, their medical history, vision, hearing, language, what environmental access they might need, if they can read, and what their cognition looks like. Because, especially with kiddos here that you guys have, we have complex bodies, we have complex language, we have complex cognition, we have a complex medical history, and if we don't actually consider every single piece of that, we're not going to get a system that will be the best fit for your child. So some examples, and I know some of you guys have children or patients who don't go to one institution for everything. So what I would suggest is before going to your AAC eval, just make sure you have like input from your PT, your OT, your school teacher, so that they can have that information readily available. So one example is if they're getting physical therapy, they can give input about mobility. What kind of support do they need when they're sitting down? What can they sit on their own? Are they walking around? And then access could be occupational therapists could show you like what kind of fine motor skills they have, what type of visual attention. If they're looking at everything and if they're able to see things and process them, those things are all important. Or environmental controls, you can give that input. For example, you can do, like, we have really good technology in 2024, so you can use Siri, you can use your device to turn lights on and off. Just yesterday, we programmed Siri for one of my patients, and now he can say, hey Siri, play Blaze on YouTube, and he was so excited about that, because that gives them more independence, right? So I keep talking about access methods. What does that mean? So the one that we're more familiar with is touching the iPad with your finger. That's probably what we've seen before. We can use our eyes, or we can even use switches, get pretty creative. We actually had a patient who used their head. Yeah, woo! We used their head to touch because he had a hard time kind of reaching out to buttons. And I think this company used like pipe cleaner things, like tubing to kind of make this, so it can be pretty creative and pretty individualized. And then it could be scanning using switches. And if they have visual impairments, sometimes we have parents or communication partners take a board. Can you hold that one up? And the communication partner will auditorily read out the options, and then they can pick using a switch, raising their hand, saying, whatever that looks like for the individual child. So again, it should be individualized. Every kid is different. Every kid has different needs. And if somebody's trying to put one specific system, it's probably not the best case scenario.
It shouldn't be the system that the therapist knows best, and it shouldn't be the system that the school system only uses.
Yes, we do run into that. So I think just being aware of it could give you some power, right, to kind of fight against that. Some factors to consider once you have decided what type of device they need is, one, going back to the vision, right? That kind of gets put aside all the time. But can they see? What does it matter if you can give them a 60-page or 60-button vocabulary if they can't see it, right? And we're not just talking about looking with your eyes, but like seeing the information and processing the information. And sometimes we have to decide between real pictures versus like symbols that are on there. And if they can understand the symbols, I often start with real pictures for younger kiddos because that's what's more familiar. And then we also think about like the numbers of vocabulary on the page, what size they should be, and then we sometimes use a checkerboard layout. Looks like that, where we hide some parts of the page so that their attention can go straight to the buttons that are important. Versus what was on the picture earlier. I don't know why I'm on there. But what was on the picture earlier. And then to help more with the vision and visual attention, sometimes we will put like a black background or a black sheet behind the communication system so that when they're looking, there's black and then they can kind of focus on what's in front of them. Some more factors to consider, accessories. So we kind of talked about the mobility piece. So if they're walking, we might want to consider having a strap so they can carry around their system. If they're on a wheelchair, we might want them to have a mount so that it could always be with them. Some wheelchairs already have that ability, I think most, have that ability to just add the mount right on there. So it's not a big process. And if they're using an eye gaze device, we might use a table mount or a floor mount so that we don't have to recalibrate the vocabulary every time that we're using it. Key guards is a really simple fix to a lot of difficulties that kiddos run into, because a lot of times they will kind of go at the device with their whole hand and touch everything, and they get frustrated. So when there's a key guard, it kind of stops them from, allows them to touch the screen and then kind of figure out their fine motor movement from there. So we have the device, we have our vocabulary, what do I do? If you guys have been in speech therapy for a long time, you probably heard model, 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 model. What does that mean? Our instinct is to quiz. So especially when they're starting to talk and they sound so cute, we want to be like, what's that? How many? What color? Can we count? 1, 2, 3, so we just are forever quizzing them. And what we want to emphasize is we want to pivot and have a mindset of modeling. So instead of saying, what's that? We might say, look, it's a bird. It's a red bird. They're flying. They're saying, tweet, tweet. They're 2 birds. There's so many more things that we can do, because we also don't walk around to our friends and family and say, I want goldfish. I want bird. I want drink, so we want to show them we're not just requesting, we can comment. Look, it's a bird. We can ask questions. Mom, do you like birds? Do you see the bird? Gain attention. Mommy, look, so we always want to model these different types of language interactions on top of, their addressing their basic wants and needs. Tap and say. This is a fun one. So a lot of times when we first invite parents to come in and try the AAC system, this is what we see. So they might say, oh, Joe, do you want
cereal?
And it's like, okay, but you're using their voice, you're using your voice. These are 2 separate things, right? So we want to tap and talk at the same time and make it seem natural. We don't want to just let the thing talk for us. So we want to say, oh, do you want to eat some cereal? That sounds yummy. Let's get cereal, right? So just continuously model on here as if, and don't worry about what this is saying. You just want to keep on talking to the child also. Can we show? Okay, thank you. And then we want to attribute meaning. So if the child is sitting there eating his cereal, has cereal all over his face and smiling, that probably means they're enjoying it, right? So even if they're not saying, Mom, that's yummy, we want to give that meaning to the child and say, oh, you look like you're having a great time. You look like you love the cereal. Is it so yummy? And give them that meaning so that they're hearing it over and over. They're getting that input. And then if they ever say, for instance, cereal with a smile, we want to repeat what they said, cereal, and then we want to add another word. So for instance, I would say, oh, you want to eat cereals, and just kind of add one more unit than what they said to us, and then repeat it back to them. It's like, oh, what do you want to do? Eat cereal, right? Okay, now that we have those strategies, I know I'm giving you lots of information, but one thing, this is like an important mindset shift that we all kind of take and we try to keep in the back of our minds when we're implementing those strategies. So 1, reinforce and accept all forms of communication. So when we're talking to people, we are talking with our words, we're texting, we're emailing, we're FaceTiming, and if we don't want to talk, sometimes we just shrug, give a thumbs up, give a smile, right? So when we're working with our children, we don't want to be like, you have to tell me cereal, because whatever way that they want to communicate in that moment is still valuable. And you want to take turns. This gets a little awkward because a lot of times as a speech pathologist, I'm talking to myself. But we don't want to just talk at the child. We don't want to say, oh, we're eating cereal, eat cereal, cereal is crunchy. Do you like the cereal? Cereal is good, right? We want to give them the pause and the opportunity for them to comment, for them to express how they're feeling. So for instance, I might say, do you like cereal? And it could be crickets. 5 seconds, 10 seconds of crickets, but that's okay. You just kind of read their body language. If they're reaching for more, it's like, oh, it must be yummy. Do you want more cereal? And just continue to take turns so that they're expecting that you're not just somebody you go to when you want something, right? You can teach them that like they can communicate with you whether or not they want to request something from you. Attempt to get a response. Yes. So after, it's okay. We always want to get a response. I know that is everyone's goal. We want them to communicate with us and to us, but do your best to attempt. My rule is like 3 strikes and you're out. So try 3 times and just move on, because it doesn't always mean that they're not listening to you. What I usually find is like in the next activity, in the next session, they are using the concept that I was working on them with. And then if there's anything to take away from this, presume potential. I think this is really important. Assume that they are and assume that they can, and that always helps us naturally affirm them a little bit more easily and more naturally. So I might have a parent who comes and says, you know, they always say like papa, but I think they're saying pizza. I don't know. Like it's kind of, I'm like, they said pizza. I think they said pizza. You don't think they said pizza? You know, just give them that benefit of the doubt and continue to reinforce it. And eventually they will start to use like a specific vocalization for a word, and boom, there's communication, right? We've handed this out. We have some more copies. It just kind of talks about like a hierarchy that we would use to prompt our children. So moving from like the most support to the least support. It's not a level situation. It might look like this for every single activity, every single word. So it's kind of a fluid back and forth and just gauging what they need. And then Model as a Master Pal is a resource we recently learned about, and you can look it up online, just on Google, and I think there is a website called Parents Help Parents, and it has modules, and it has handouts, and it kind of, again, runs through everything I just talked about very quickly in different, more specific, and provides strategies for you guys. That's okay.
I wanted to regroup and quickly summarize what we've learned about from working with a number of CACNA patients, and just kind of summarize for you what we noticed and what we think is working. And I'm going to zip through vision problems. You know, I'm just going to zip through this so that we can get to what the trends are, and then you guys can ask some quick questions. The biggest thing with vision, I think I was talking to somebody at the dinner table last night, that that affects communication is sometimes a lot of your kids cannot look and talk at the same time, or look and reach at the same time. So giving space and knowing that, and just making room for that. And then also how, you all know this, how fatiguing it is. So, and leaving room and space for that as well. And shifting your communication to something easier when you're exhausted, they're exhausted, the environment is not conducive. So zipping through these things, I think she covered a lot of the visual concerns, and you have an amazing thing coming up right after me on cortical visual, and I'm not going to even pretend to be an expert on that. But these are the trends we've noticed with your kiddos. So the things that help, I'm going to talk about the things that help the patients, and then the things that we've done with caregivers for your specific groups of kiddos. Again, there's a lot of change and variation in that, but I wanted to just show you the changes, the trends we've captured. So first thing is environmental supports. Every single one of your kiddos, and adult kiddos actually, so every single one of your, I don't know, anyways, environmental supports make a huge difference, okay? You can change a communication success just by helping make the environment supportive of that. Structure, context, routines. When you can structure something, repeat a routine, and use context, you're going to have more success. Using vocalizations, gestures, and speech, that multimodal communication, what's fastest and best in the moment is fastest and best in the moment, and accept it. And then we have found the kids that we all saw obviously had at least one intensive bout of speech therapy. So 4 to 6 weeks every day, it made a difference. And I've had people say to me last night, you know, how do you know when it's time for that? How do I not feel guilty for doing that? How do I, you know, explore when's the best time to do that? So I would say one intensive bout is always worth it because you won't know if it made a difference until you try it, right? And I would say that there are times in your child's life where you know that an intensive bout is a good time and an intensive bout is not a good time. This is not the time for me to upload my family and go to stay at Ronald McDonald House and go get therapy 3 hours a day and change my whole routine or whatever. But there are times where your child might be closer to getting a milestone, like walking or talking or a device, where that intensive bout would be very helpful versus one time a week or doing the things you're doing at home. So work with your teams that you have and make those decisions. And then for every single one of our kiddos, we needed your expert on your kids. And so then there's an important part of caregiver training. We need to teach you what we know about speech therapy. You know your kids, you know CACNA. We do not know CACNA. We're learning, thanks to you. But we are going to teach you the strategies we know so that you can do that at home. You know, an hour of speech therapy is not much, but an hour of speech therapy plus you doing it at home every day is way better. So the things that we teach are that multimodal, just getting you comfortable with using the quickest, easiest way in the moment, teaching you ways to lower your language levels, teaching you ways to prompt speech and expanding speech. And then I love that 3-step guide to compliance, say, show, do, say, see, do. I think that's very helpful. Using AAC devices and teach, do not quiz. Don't say, show me. You know, so if you just go back to basic brain development that we know, you need to develop the right neural pathways. You need to give the model and you need to set up that motor plan and those neural pathways to the right answer. So when we're quizzing and they get the wrong answer, you just set up a neural pathway to the wrong area, right? So teach, teach, teach. Don't quiz. And then you guys are going to have a whole thing about creating a plan for your kid, and I know you have that this afternoon, so I'm going to zip through some of those. I do recommend, if you can, and it's around you, try to get to an interdisciplinary team and one of these LEND centers or someplace that has some experiences with rare disorders. These are lists of some of them. I think you guys have an even better list. So types of therapy models. School-based therapy is good. I hear lots of times that my school is not great, but stick with it, have at it. It's in a natural context of where they are, so that's always really good. You can do push in, pull out, outpatient, private, and then just knowing, you know, for little kids, you're going to try and get a IFSP for 0 to 3. For the 3 to 21, you're going to get an IEP, and then you can access those through your infants and toddlers and Child Find. Okay, I'm going to zip through. So I'll just do this. Final thoughts. You guys are experts on your kids. You're amazing. And you're the most important part of your kids' team. This is going to make me cry. One of the parents of one of your champions, it's Adeline. It's not the Adeline I know, but one of the best things I read was the thought of inch stones. So I need to read it to you. Actually, I'm going to have one of you guys read it. Yeah. Sorry.
Adeline's mom encourages you to focus on inch stones versus milestones. She said, for our kids, milestones are the result of a lot of hard work, tears, and many, many inch stones. Those inch stones should be celebrated every step of the way. It is difficult to change your mindset from milestones to inch stones, but once you do, there are so many celebrations along the way.
You guys said it best. So we've talked, but if we'll take questions or we can be later or whatever, but I'm available to you and I want to hear your questions. So we do? Okay.
Okay, we have several online questions. So
Okay.
maybe we'll start with one and go back and forth. Okay, so one parent says, my son is 19 and speaks okay, but not great. After a big migraine, his speech is terrible, and it takes at least 24 hours for his speech to come back to normal. What can we do to stimulate the right speech sooner?
I would say that the reason why his speech isn't coming back quicker is because his brain is recovering. And sometimes you need to go to nonverbal communication and simplify the language load. I know that's not the answer you wanted to hear, but there's a reason why that system is not coming back up quickly.
Just quickly, I just had a quick comment. Some of us parents were talking yesterday, and we realized that there was something also about the dental situation, and we were wondering if we were talking earlier about, communicating with medical professionals, maybe dentists or orthodontists or people who are actually looking at all this oral, kind of more, motor thing, might be also people to communicate with about the specifics of CACNA. Some people were saying that when we lose a tooth, for us it's a very big deal because it could take us way back in the progress of speech for several, months until the next tooth comes in, and things like that maybe might be related. I don't know if that's...
So I can tell you, at Kennedy, we see rare disorders of all different kinds. CACNA is one of them, but that has come up, and there's actually a family that works in Russia, and they bring their child over to us, and she's a dentist, and she's doing some research and looking into that. I don't think her son has CACNA, but he has another rare disease, disorder, I'm sorry I said that, another rare genetic condition that affects a lot of the same things that your kiddos have. And then there is a dentist in Baltimore who works with kids with special needs and is kind of looking at some of these things too. I don't have a lot of information yet, but if I get it, I'm going to send it to you, okay? So, but you guys found something, and we're catching up, so.
Okay, we're going to do another online question.
Yep.
So this is from someone who writes, my daughter is able to use 1 to 2 utterances on her device and has a clear yes and no. We've been working on identifying feelings and tools to help depending on the feeling. She is 9 and has more to say than she is able to. Is there a resource for identifying those deeper feelings and the reasons for those feelings? We're trying to figure out what to add to her device to help her explain why she is having the feelings behind when something hurts, being mad or frustrated, and we get, I feel like, screaming and yelling, and we want to be able to help her communicate in other ways. Do you have suggestions?
This is the number one question I'm asked. If my child is in pain, how do I know? If they're hungry, how do I know? How do I know what this crying means? The hardest thing about feelings is they are a very abstract concept. This is where the teach versus ask is really important. When your child is experiencing that feeling, you want to put words to it. Single, simple words. Figure out what your family word is for that feeling and reinforce it. Once you figure it out, if your kid's in pain and you realize you're in pain, it hurts. You're in pain, it hurts, that kind of thing. I would say for the person online, work with the team that helped you with that system. Do you guys have any other thoughts?
So going back to like the modeling, something I like to do with when parents want to work on feelings is while we're working on books, model that way. Like, oh, look, he fell off his bike. Oh, he hurt his leg, and just kind of teaching it in that way. And hopefully they can eventually generalize some of that to themselves.
And social stories. Do you guys know what social stories are? That's one of the best ways to do it. So.
And I also think, too, just going off of that, if your child really likes a specific video or show and a character is really important to them and they can see their favorite person experiencing something they're experiencing, that's also a great way to teach that.
So teaching is really the key in ways that are functional in your moment and in your life. So with motivating things. I wish there was an easier answer to that because that is the number one thing we all want. Yeah, go ahead. If you guys have suggestions?
It's a good thing Emily isn't in the room right now because it's embarrassing. But she likes Caillou, and she's 27, and she still likes Caillou.
Yeah.
And
Caillou's great for that.
Caillou is really simple. So he has emotions and he does things, but there's not. I know TV today. There's just so much going on, but not in Caillou. So it's a good way to sometimes put words to those. Yeah.
Okay. Yes. Okay, so I have a couple of questions, actually.
Where's the speaker? Oh, I can't.
Yeah, I'm over here. Sorry.
Oh, thank you.
So a lot of you have met my daughter, Amelia, and she can be the biggest chatterbox that ever was. But over the last year or so, she's regressed a little bit with her speech. Sometimes she has some memory issues, memory recall, So she'll either start like whining, or she'll be in the middle of a story and it'll be really hard for her to get the words out. So one of my questions is, how can we help her in that moment? Because I can find sometimes as a caregiver that I can get really frustrated because I know that she can talk. And then, sorry.
I can relate.
Yeah. And so then one of my other questions was about the eating. She also takes a really long time at meals. She takes very small bites, but if anything more than that, and it can trigger her gag reflex, and she has a lot of issues with that. Some of it is her just getting distracted during meal times, and some of it is just because she takes such small bites, and it will take her an hour sometimes to finish her meal. But she's 6 and only weighs 35 pounds, so like she can't afford to lose any weight. But like you said, sometimes I feel like she's burning more calories than she's taking in. So what can we do to help her?
So let's talk offline about that, the feeding piece. And then your first piece, I'm sorry, do you guys?
Yeah. Oh, go ahead.
When I was listening to your first question about like being in an emotional state and not being able to get her words out, my first thought was going back to what can you use in terms of multimodal communication? Because you're right, you know that she does have the words to say it, but really looking in that moment, what is she able to access? That doesn't discount what she can do verbally, but if you need to then take it a step back and use pictures, use objects, use choices, that is, you want to create a space where she also then feels validated to communicate and accepted in the ways that she can in that moment.
And something to emphasize with that is, I mean, thinking about it with ourselves, right? When I'm really upset, words don't come out of my mouth. It's like they're stuck in there, and I know how to speak to you, you know? And I think just having some of that compassion and just being like, you know what, you're just like me. Even though this is something we're working on, I think that it's important to just remind ourselves and have that mindset.
Hi, Christina. I just thought I'll mention, because my daughter's eating is very similar to yours, and she gags, and her food has to be really small as well. So we do mixed feeding, and we also give her a complete and thorough nutrition, which is like a milk formula, and 50% of her nutritional intake is that. I don't know if you guys are already doing that. But what I was going to ask is, so you mentioned that use of AAC does not inhibit speech. Would you be able to elaborate more on how use of AAC can still develop speech? Because I think that's really maybe not something many people know.
Yes. Let me get the big iPad.
We love talking about this, by the way. We love talking.
One of the toughest things is there's still a lot of people believe that if you use an AAC device, you won't talk, and it's the opposite. So it goes back to brain. So I am also a brain injury specialist. It goes back to principles of errorless learning. It goes back to setting up neural net pathways. A lot of my kids who use devices end up being early readers because they're seeing pictures and words in front of them all the time. We are oh my gosh, help me. we are modeling on these systems. So if I'm talking to you, you have one way of input, right? It's just your ears. If I am showing you and touching, I am recruiting vision, I am recruiting tactile, so you're using more and more parts of the brain to get that input in. Does that help? So if I wanted to say, I eat pizza, which I do. You know, I'm gonna be talking to it, I'm modeling it, I'm showing it. If I just say to you, I eat pizza, what do you have to do? You have to be paying attention to me, you have to know those words, and you have to be hearing them fine. So it is, the beauty of it is you're giving modeling language, you're expanding language, and you're recruiting different parts of the brain.
And my favorite piece of it too is if they have dysarthria like we talked about, or apraxia or fatigue, they're probably communicating to you with like one word or two words. But what this could help too is like developing, like what Lynnley put, a whole sentence, right? So kind of developing that sentence structure on top of just learning language. Whereas like if they're just talking, they might not have the
speech
strength
capability.
or the speech to say, I want pizza. They might say pizza. So having this as a supplementary piece of communication and learning language could help give them that input as well.
I think for a lot of your kiddos, I keep saying kiddos, and I remember there's older people in the audience, so I'm so sorry. I just see all the kiddos. I just forgot. Darn it. Gosh, don't get old. Shoot, it's gone. It'll come back and I'll say it, but, oh, shoot. Oh, well, it was good. I'm so sorry. Oh, yeah, go ahead.
Hi. Our daughter's 14, so she's on the older end.
Yes.
She's transitioned from pointing at the pictures at school to
Yeah.
a notebook
Yeah.
where if the teachers or somebody couldn't understand her. But we still struggle with her at home. Sometimes when she talks, it's just, she drops sounds, she forgets. And the one thing I've struggled with every speech therapist we've ever had is I've asked about oral motor planning, exercises, and how we can help her build up that endurance and the muscles, and because that's the research I had to do on my own to figure out that's where she was really lacking. Do you have any tips or pointers or things where we can go to and learn about and help to give to some of these therapists? Because that's the one thing, as many times as I've asked, I've never gotten anything beyond like, give her a sucker to suck on or something to that effect. So
I don't think the lollipop's going to make a difference. It'll
I
taste
don't
good.
either, because she's had
Yeah.
lots.
Yeah.
But it's just trying to help her figure out how to get those sounds out. Because for the most part, we can understand what she says, but there are times when it's really hard and she gets really frustrated.
So the first thing I'm going to say is, that's called a communication breakdown. And in that moment, I want to teach you really quickly how to fix that situation. So I understood this, I understood that, but I didn't get this part. Can you tell me in a different way? Lots of times kids will repeat the same word, I'm like, I'm sorry, I didn't get that. So I'll say, use a different word. And if I can't get it, then I'm going to say, is this about you? So our brains store language by context and grouping. So you're going to say, is this about you? Is this about me? So you want to find out that context or that category group that it comes from, and you'll be able to repair that communication better. So if for some reason, and it often happens when your kids are talking about one thing and then they just quickly tell you something out of context, like suddenly something pops in their brain and they're like, that Superman movie was great, except it was like, oh. And you're like, I don't have any idea what that was. And I know it's important because you can see from their body it's important. So you're like, wait, I didn't get that, be honest. And so can you tell me in a different way? Can you use a different word? Is this about you? Is this about me? And kind of work through some categories. So that's the communication breakdown piece, because that's really what's happening in that moment. The oral motor speech piece, there's no easy answer there. I can tell you in our field there's a strong group that say oral motor's great, but I'm all about function, function, function. So you can work on a chewy tube and you can do those things, but that teaches you to work on a chewy tube and do those things, right? So you need to practice what you need to do when you do it. So a really good differential diagnosis is what your daughter needs from someone who knows those areas. And then the other thing that we've learned, or I've learned, we've all learned actually, is if your daughter can learn to mark the final sound of words, that's how your brain marks meaning. So you don't have to have specific sounds, but if you can mark each syllable of a word and you can mark that final sound of a word, you can, great idea. You can make a huge difference. We also will slow down the process and recruit different parts of your brain visually. Elephant. Well, that's a really bad word because none of our kids are going to use that. But I don't know. Give me a word. What? Doe. Tell me more. Dog. Oh, okay. So you can use a pacing board for different reasons. You can do dog. You can do dog. Well, dog is one syllable, so I need a two-syllable. Yeah, goldfish. Thank you. So goldfish, right? So you can use. We'll just have blank boards like this. I've had 2, I've had 3, it depends on what I'm working on. So if I'm working on final consonants, and also you're gonna start with functional, easier words and then work up in complexity. So I might have just 2 circles if I'm working on a vowel consonant word, so like up, right? And I get so I may be p, and then I'll give a cue, p, right? So there are a lot of structured oral motor programs, and there's not one that's good for every one kid. So there are some Kaufman programs, there are some dynamic training programs. So again, getting to someone who can give you a good differential diagnosis will be the person who can help you there. I know it's not the answer you wanted, but.
And I just have one other
Yeah.
piece that I wanted to just add to that. Consider the time of day also when your child is communicating. If they have fatigue, think about, okay, maybe towards the end of the day, they're going to be really tired. If we see their body being tired, we're going to also see that in their oral motor structures. So figuring out what time of day is better If they're really tired at nighttime and that's when you're seeing more communication breakdowns, use multiple means to support them and decrease that frustration.
Sorry, I'm gonna add one more thing. For going back to oral motor and function, I think kids learn to say sounds when they're saying sounds. So if they're learning, if you're kind of like what Lynnley said about up, if they're dropping final sounds, what I like to do is help them understand that they are dropping. Like if they have the awareness of it, sometimes they're like, and I'm like, what? You know, and just giving them that awareness that they are dropping, because it kind of sounds like from what you're saying, it's only sometimes. So giving them that awareness and just tell them, oh, you forgot the p sound, up, and just continuously reminding them. And as they're getting reinforced and affirmed that it's better understood when they do mark the sound, I think that would increase too.
And I think in your daughter's case, simplifying, if she can figure out how to get the key words of the meaning when she's tired, that would help. And probably the final consonants, because of dysarthria for her is what I'm thinking, but I don't know her.